Today, we're going to outline our solution, which is extension of Optum's OB home care services to select patient populations. We propose the extension of Optum's OB home care services from only high-risk pregnancies to also include low-risk pregnancies that are stratified by socioeconomic status to improve overall outcomes, to build on an existing infrastructure that already exists within Optum. We know that geographic disparities to access to care, in addition to social determinants of health, cause poor outcomes for select patient populations in this country. We've also seen that community-based initiatives have been successful in generating positive ROI, all while increasing access to care and improving overall outcomes. What we're proposing is the extension of their OB home care program using their existing infrastructure to decrease our reliance on high-skilled workers such as nurses, and also to shift the cost burden off of large payers. The data reiterates that low-income women and women of color bear the brunt of the significant costs of care associated with poor outcomes in this country. We also know that these disparities place large cost burden on the system overall, with $50 billion in costs attributed to these disparities each year. The geographic maps at the bottom of the slide show low birth weight and maternal care deserts overlaid over each other. The darker the purple and the darker the pink, the more that these factors are present. You could also see median household income projected with infant mortality rate for Black and white women, as well as percent low birth weight. You could see that the poorest outcomes are associated with the poorest people, but also that Black women have 2 to 3 times higher the infant mortality rate than white women for every single household income level. Clearly, any effective community-based initiatives will need to center on these factors in order to be successful. These 3 initiatives are maternal home-based care programs that have been successful in these realms. They've all demonstrated statistically significant improvements in outcomes such as preterm birth, infant mortality rate, and low birth weight. But in order for these programs to serve as models for our solution, we also have to address their limitations. Namely, these programs are far too reliant on highly skilled workers such as nurses, which we know from the COVID-19 pandemic are subject to labor shortages and are also very expensive to retain and train. These programs are subject to word-of-mouth referrals and also are completely dependent on state and local government funding, which makes it difficult to scale to a regional or even to a national level. My colleague Megan is now going to go into the specifics of our solution.
Thank you, Zach. So currently, Optum offers OB home visiting programs as a care management model, primarily for high-risk pregnancies, leveraging clinical nurses to provide some clinical care at the home, as well as doing some educational and telephonic support. This program does provide sort of that base infrastructure and some tested methodologies with home visiting. However, as we've discussed, we're looking at disparities in low-income women, low socioeconomic, particularly how we address shortages in clinical workers and also the cost associated with that. So we're looking at expanding this program, just kind of using that infrastructure, but employing maternal community health workers. So these are non-highly skilled healthcare providers that would go through about a 3-month intensive training program to deliver perinatal education and do some very basic health checks to increase education, provide guidance, and initiate referrals when needed. The main goal here is to also help get that longitudinal relationship with someone who's similar to you, who a similar demographic, and help to erode some of those barriers to trust in the healthcare system and reduce some of that effective systemic racism by giving someone a trusted partner throughout their pregnancy. Additionally, by looking at this as sort of a product expansion, we're able to leverage some of Optum's existing tools within this one product, looking at a 24/7 nurse support line that a member could be directed to call, and coordination of care capabilities. Now, looking at the broader suite of Optum products, this allows this program to be further enhanced and refined to increase the effect. So Impact Pro, essentially identification and stratification tool, can be modified to help identify the pregnant individuals who are most likely to benefit from this program. Zach talked about some of the factors earlier related to income, minority population, zip codes based on geographic care disparities, et cetera. Of course, then segmenting out high-risk OB that could be covered elsewhere and are not appropriate for someone with a lower level of education to be working with. Additional maternity support care management programs have sort of a fundamental education program that could be scaled down and leveraged by the maternal community health workers. And then provider assets, as well as care management staff that have developed these programs, are already well positioned to deliver that training that would be needed to upskill these community health workers, and where possible, act as part of the care continuum if the member is seen an Optum Care provider. And the relationship with United Healthcare provides an ideal insurance partner for the initial pilots, specifically in terms of markets where they're doing managed Medicaid, which we know is a very high factor, as demonstrated in our graph earlier. So now let's kind of talk a little bit about the program and how it works. So maternal community health workers can be trained to deliver a standardized curriculum to mothers during pregnancy in their first year postpartum. So how this works, it centers on home visits to create that longitudinal trusted relation and erode some of those barriers to trust. They would be bi-monthly in the first year, they would be bi-monthly in the pregnancy and first 3 months of the child's life, centering on sort of education, basic health checks, things like blood pressure to screen for hypertension, blood sugar for gestational diabetes, doing some postpartum tradition and basic child caring skills, and then looking at that kind of 3 to 12 month tapering off to 1 visit per month, doing more of developmental milestones, basic education, and kind of pulling them out of the program. The curriculum, as we mentioned, would do some of those basic clinical checks, but mainly focus on education to meet the needs of the population. Things like basic nutrition, how to mix formula, benefits of breastfeeding, a little bit on childproofing. The benefit of being in someone's home is seeing what they're working with and recognizing where there may be gaps and pointing some simple things out like, oh, you haven't done this, your crib is here, let's talk about that, that require a little less education on the part of a community health worker, but may be a barrier that someone doesn't know who's in one of these populations. And then when we think about recruiting the maternal community health workers, they need to come from demographic communities in which they're serving to have the maximal impact on helping to erode some of those barriers to trust and reducing the impacts of racism. Now, this is sort of a double play with equity. Maternal community health workers could be recruited from traditionally overlooked populations, thereby providing a path to a well-paying job for those communities and eroding some barriers to equity in terms of the cycle of poverty and giving paths to jobs there. We can also look at kind of career laddering people as the program goes on to provide growth opportunities. Now, our program is estimated to cost roughly $3,500 per patient, plus some additional startup costs. Now, this comes down to about $170 monthly. This includes the initial training cost production, which is higher than your standard care management program. But this is a home visiting program. We have costs to get people to the home. And as you kind of train and build that workforce capacity and need to just move to continuing education, you'll see that training cost and overall cost decrease. The benefit of a lower startup cost and building off an existing product infrastructure is that you get a lower barrier to starting up the program, looking at kind of modifying existing program materials and existing algorithms. And then we anticipate around a 2-to-1 ROI, although since it's a new model, it may change. We're not quite sure. We're seeing the home visiting programs with nurses averaging 4 to 5. We recognize we're using much lower skilled workers, so we're going to see a reduction there. But traditionally, care management programs are hitting the 2-to-1 ROI mark. And so that's what we're anticipating is likely going to happen here, but of course, you can't be quite sure. Now, we developed a go-to-market plan that leverages United Healthcare's and Optum's capabilities to train the maternal community health workers, pilot and refine the program, and then bring the program to market. Of course, identifying the target health plans, leveraging relationships that already exist and where you're selling these products already. This could be bundled in as an add-on, but we're going to start with a pilot to learn and to refine our program, ideally with United Healthcare in a market where there's managed Medicaid, where we can target the population we want, where we have a high presence and can kind of get a lot of things working in our favor to learn about it. Then we're going to identify them through programs such as Insight Pro, doing that identification and stratification to identify the women who we think will benefit most, have the maternal community health workers reach out to them to encourage them to enroll in the program, recognizing, of course, like any program, not everyone will enroll, and then establishing KPIs and monitoring progress to measure efficacy and continuously improve the program. On the longer scale, we would want to then expand the availability as a product you would go to market with across all insurers, maximizing reach across the country. Now, this go-to-market plan ties in with our timeline here. We give some time for ramp up in terms of developing the training, doing that recruitment that you'll need in the pilot market and preparing to launch, going live with an initial pilot in years 2 to 3, doing an internal cycle of lessons learned, expanding to additional pilot cities, and then looking at expanding as a product no later than year 5 to the broader market. Of course, one of the limiting factors here is the human capital in terms of hiring folks, but we think that there could be sort of a continuous cycle of people coming in. So now I want you to meet Monica. So Monica is a Hispanic low-income mother with no past medical history. She wouldn't flag as a high-risk pregnancy. She lives in a maternal care desert, and her 2-week-old son was born in a hospital without complications. She's been enrolled and has had a maternal community health worker visiting her bi-monthly during her pregnancy, and she notices her son's face and upper chest starting to appear yellow. He's jaundiced. So she knows from her maternal community health worker, oh, maybe this is something I should watch, and reaches out. The nurses confirm a little concern, connects her to Optum's 24/7 nurse line, reminds her, this is something maybe we should go to the ER for. So she goes, the jaundice is treated before there's any resulting brain damage, and our total cost here projected is much lower than what could happen if she doesn't have that kind of trusted resource to reach out to and hasn't been taught about those red flags. And this journey, without the prenatal programming, we're seeing that she doesn't kind of take action. She's not quite sure what to do. Her son becomes unresponsive. She ends up in the ER. But the jaundice is not treated before her son suffers permanent brain damage. So not only are you kind of having the higher total cost of the acute care, you're getting longer term costs to treat that permanent brain damage. You're also seeing long-term effects on Monica's family and her way of life and how she does life with a now long-term disabled son. So we believe that expanding the existing home visiting program and segmenting out a portion to look at low-risk women using maternal community health workers will help to lower costs for payers and for patients and build on existing Optum health infrastructure to improve health equity at a broader scale and help to close some of these gaps and disparities that we're seeing in maternal health care in the U.S.
The $3,500 per patient is pretty high.
Yeah.
And you talk about a 2-to-1 ROI, but I assume you're comparing that to high-risk care management because there's not a lot of low-risk care management to compare to. But you're talking here about low-risk care management. So how are you going to have the same ROI because the patient costs are going to be less?
Yeah, great question. So yes, the 2-to-1 ROI is seen in the high-risk OB programs. McKinsey also conducted a study looking at sort of broader care management programs, everything from chronic disease care management, which still does typically hit the kind of higher echelon of patients, and other care management programming that is seeing that 2-to-1 ROI. We went with it because programs like Nurse Family Partnership are seeing over a 5-to-1 ROI. Doing a very similar type programming, they are using a nurse. We know that's not feasible, not using someone as skilled as a nurse. And so our best estimate was to significantly discount that and then look at what we're seeing for care management programs across the country. We do know that social determinants of health and barriers are attributable to 80% of health outcomes. And a lot of the things related to infant and maternal mortality or morbidity are largely preventable and heavily related to education and access to care, which we believe even at that low risk level, we can start to get at. Also, having someone who's trained who can recognize this feels like we're getting to something kind of beyond my scope. Given the broader suite of Optum care management products and those high-risk products, they can initiate that referral when it gets there, potentially before a model, an algorithm which is using claims data, which can be delayed, flags that as, we have maybe a high-risk OB patient. It goes into a care manager's queue. That takes them a while to work and get to. They can make it directly and get them into a higher level of care management if needed and capture some cost benefit there.
So in your model, are the visiting nurses or individuals, are they employees?
Yes. So that is the model that we've modeled. We think kind of pulling them into the Optum network has advantages in terms of employment and doing that training. If you were to try to outsource it, Optum would incur additional cost of outsourcing. And you have a lot of let me flip back this way, things to leverage in terms of training and doing that curriculum development. People who are already doing kind of care management those nurses can help be part of teaching. And then, as a company as large as Optum, you deliver training programs to your employees all the time. You know how to train people well and can scale up that programming. Having them in the Optum network also kind of at least in what I've seen, you can give them better access to different data. You have a few less privacy concerns when they're looking at patient charts and what they're seeing in the care management program that can allow for better connectivity than if you were to use someone not licensed through your own system.
I know community health workers has been around for a while. I'm
Yeah.
just curious if this is an untapped market using community health workers in a new, just specifically focus on the whole perinatal and maternal care aspect, because I haven't heard of that before, but I know community health workers have been around for 10 years or so in existing programs and developmental features like pen medicine with the impact model. So I'm just curious if it's just brand new.
Yeah, so we haven't seen them, at least not in the research that we've done, being used specifically here, where you're training someone more intensely in a more niche space. But yes, they started, community health workers have a long history in public health, starting out a long time ago. They sort of phased out in the US. We saw they're used internationally now. As we're seeing sort of healthcare trending back towards the block with like startups like City Block and other people, we are seeing the resurgence of community health workers, but we haven't seen them particularly here and targeted in one area where they can kind of gain expertise, continue to gain it even through continuing education in the program, and delve into one thing like this.
Yeah, and just to echo Megan's point, we didn't see anything in literature looking at it, and the curriculum we derived is completely unique based off our individual experience, both in the healthcare equity space, as medical students and as dietitians. So it's kind of a uniquely crafted, but also Optum would definitely kind of gather their physicians or their dietitians to mold for that curriculum.
Yeah, the curriculum also pulls off of what we're seeing the other nurse home visiting programs do.